Okay, good afternoon, everyone. Welcome to the fourth day of the Congress, NPMF to 2021. We all wish we were together to meet and discuss, but this is the best that we can do. I'd like to thank Tatiana, Ursula, Artem, and the team for having made this a great platform for us to communicate and learn from each other. So we will start the first part of the program today, talk by Professor Arunas on surfactant oxygen saturation targeting. Please type in your questions either in the Q&A box or in the chat box. Also, give your evaluations or feedback about how the Congress is going. So hopefully we can make more changes. I look forward to another great day.
Hi, dear colleagues. Today I will talk on surfactant, oxygen, and target saturation and the delivery room. And I think that it's very important topic for the preterm babies when we're talking about the stabilization of these babies. And general conditions, short and long-term outcome of the premature baby very much depend on appropriate steps of stabilization at the delivery room. And in that regard, minimal invasive therapy becoming a standard of care during the stabilization of very low and extremely low birth weight babies. And very important part of this stabilization is optimal respiratory support, including rational surfactant administration and appropriate oxygen supply. And actually, we will stop today on these two important topics, surfactant and oxygen, and what are the current approaches to surfactant administration, surfactant and oxygen administration to the baby. We are basing now. We are coming back to European consensus guidelines on management of respiratory distress syndrome. I hope that everybody is familiar with that 2019 update. But in the full out of the full range of the topics, we will choose the two one. That's surfactant and oxygen use, as I mentioned. At the beginning, I want to come back to these guidelines and try to compare the guidelines of 2016 and 2019, and to stress your attention into some major changes that have been done in 2019 update. Actually, starting with the surfactant administration, the first 2 points, actually they did not differ very much. All babies with respiratory distress should be given an animal-derived surfactant. And of course, the early rescue surfactant should be a standard of care. But in some cases, especially when the baby needs to be intubated at the early beginning of the stabilization, the surfactant should be administered right from the first breath after intubation of the baby. I think that's very important point, which has changed a bit comparing 2016 and 2019, is that the babies with respiratory distress should be given surfactant early in the course of the disease. A suggested protocol would be treat the babies who are worsening when PO2 is more than 0.3 on CPAP pressure of at least of 6 centimeters. And I think this point is really important, mentioning us or reminding us that initial CPAP therapy with adequate positive pressure is as much important as surfactant administration itself. And we have to consider that. And if the baby is not improving on the initial CPAP, which is started during the first breath of the baby, and the baby has the oxygen requirement more than 30%, this is an indication to start surfactant administration despite of the patient gestational age. And I think this is important point, which was added or changed in 2019 updates of consensus guidelines. In 2016, it was mentioned that insurers should be considered for infants who are failing on CPAP. And LISA, this less invasive surfactant administration or MIST or minimal invasive surfactant therapy may be used as alternatives to insure. But this in 2019 was changed, and now it's clear that LISA or less invasive surfactant administration is a preferred mode of surfactant administration for the spontaneously breathing babies on CPAP, provided that clinicians are experienced with this technique. I think that this point is also important. The ones who are really doing very quick intubation of trachea, but not are very much familiar with the LISA technique, probably still have to stay on the older approach of the surfactant administration, or to learn how to do the LISA procedure in the preterm babies. I will not stop on this slide going through particular clinical trials. Just wanted to say that the last statement I mentioned, which is change in European consensus guidelines, is coming from the big number of clinical trials that were completed during the last years, and including the meta systematic review and meta-analysis that was published in Archives of Childhood. And we now, out of these clinical trials and systematic review and meta-analysis, we can draw certain conclusions that a composite outcome of death or bronchopulmonary dysplasia at 36 weeks is in favor of LISA, as well as less bronchopulmonary dysplasia cases at 36 weeks among survivors, and also less need for mechanical ventilation anytime during the neonatal intensive care unit stay. So the recent evidence and recent clinical trials are in favor of LISA method when we are comparing the intubation of trachea and surfactant instillation via endotracheal tube. And the last point regarding surfactant administration is the second and occasionally third dose of surfactant should be given if there is ongoing evidence of respiratory distress, such as persistent high oxygen requirements and other problems have been excluded. And we know also that we have three surfactant preparations licensed in Europe: Beractant, Bovactant, and Poractant alpha, and all these surfactants are in clinical use in different countries and different clinics. But there are some trials trying to compare the effectiveness of different surfactants, and the one is published in Cochrane Library in systematic reviews, comparing bovine and porcine derived surfactant products. And significant difference were noted between bovine minced lung surfactant extract and porcine minced lung surfactant extract. In the Beractant group, there was increase in the risk of mortality prior to discharge, risk of death or oxygen requirement at 36 weeks post-menstrual age, risk of patent ductus arteriosus requiring treatment, and risk of receiving more than one dose of surfactant. But it is very difficult to draw kind of conclusions out of this even systematic review. Because of difference of these outcomes was limited to study using the higher initial dose of porcine minced lung surfactant extract. Therefore, it is still uncertain where the observed differences are from differences in the dose or from source of the extraction. Another publication which appeared just recently, also porcine bovine surfactant therapy for preterm neonates with RDS, is also systematic review and meta-analysis on respiratory outcomes done by Italian group, led by Daniele De Luca, and 16 articles and 14 articles in meta-analysis and 16 articles in review were included in the study with almost 1,500 neonates. And it's in the studies where 2 milligrams per kilogram correctant alpha surfactant was used, there were lower BPD mortality, BPT retreatment need, ear leaks, and lung hemorrhages. So, and authors doing a conclusion that 2 milligrams of correctant alpha is associated with better respiratory outcomes compared to bovine surfactants at their licensed dose. So it means at recommended doses by the producer, by the manufacturer. And the effect of correctant alpha on BPD and surfactant retreatment is greater at lowest and highest gestational ages, respectively. So, um, um, having and keeping in mind these meta-analysis and systematic reviews, we could draw certain conclusions for ourselves that if we are using surfactants with the doses recommended by manufacturers, the better outcomes are with bovine, poractant surfactant compared with bovine-derived surfactants. Another issue is oxygen during initial stabilization. And this we could have a situation when we have hyperoxemia or hypoxemia for preterm baby. And we know that hyperoxemia leads to an enhanced production of oxygen-free radicals, oxidative stress, and tissue damage in preterm babies with a immature antioxidant defense system. On the other hand, hypoxemia, especially when combined with bradycardia, significantly enhances the risk of intraventricular hemorrhage and death. So either hyperoxemia or hypoxemia, both of these situations increase mortality and worsens the and shorten long-term outcomes among the survivors. I will not stop in the details, just will list that we know that hyperoxemia in preterm babies could cause retinopathy, chronic lung disease, intraventricular hemorrhage, periventricular leukomalacia, and other complications. So to give too much oxygen to the baby is definitely dangerous, and we should be careful with that. So what is the right or what is appropriate initial dose of oxygen in preterm baby, high or low? And we just can go to the clinical trials or evidence-based medicine and to try to find an answer which concentration is appropriate and most appropriate for the preterm baby. And yeah, recent systematic review and meta-analysis published in Pediatrics, which enrolled 10 randomized control studies and 4 cohort studies with more than 5,500 newborn babies, did not find any statistically significant benefits or harms from starting with lower or higher oxygen concentration in short-term mortality, long-term mortality, neurodevelopmental impairment, or other key preterm morbidities in the premature babies. And the authors draw conclusions that the ideal initial VO2 for preterm newborns is still unknown. Also, the majority of the newborns less than 32 weeks gestation will require oxygen supplementation at the right after being born. Another publication, meta-analysis of 10 included studies with almost 1,000 newborn babies between period 2008 and 2016, comparing lower, less than 40%, and higher, more than 40% initial oxygen concentration. Did not find differences again in mortality between both groups. No differences were shown in other relevant outcomes such as retinopathy, periventricular leukomalacia, intraventricular hemorrhage, necrotizing enterocolitis, BPD, or patent ductus arteriosus. So, and the authors also drawing the conclusion that there is uncertainty as to where the initial post-birth resuscitation in preterm infant using lower or high oxygen concentration targeted to oxygen saturation in the first 10 minutes has an important effect on mortality or major morbidity, intubation during post-birth resuscitation, other resuscitation outcomes, and long-term outcomes, including neurodevelopmental disability. So even these systematic reviews and meta-analysis could not give us a real answer what is appropriate initial oxygen concentration we should start using for the preterm babies. Now let's go back to the European consensus guidelines. And I think that these guidelines are mainly based on agreement between the experts from different countries and different groups that and the recommendation is to use an initial PO2 of 0.3 for the babies who are less than 28 weeks of gestation. Those who are 28, 20, 31 to use room oxygen or oxygen up to 30%. And those who are bigger than 32 weeks to use to start stabilization or resuscitation if needed with the room air. Another thing, and another issue is the oxygen saturation target range. And referent ranges for term infants have been adopted by international guidelines. But on other hand, referent ranges for preterm babies are mainly based on the population mainly composed by late preterm infants, but with very little representation of very preterm infants. So there are not really well designed and well done clinical studies with very low and extremely low birth babies regarding what are the optimal oxygen saturation targets for these babies. Recent international survey to determine current clinical practice and opinions regarding PO2 and SpO2 targets for delivery room resuscitation of very preterm infants. Majority of neonatologists, 77% who participated in the survey, would target SpO2 for these babies between 10th and 5th percentiles of reference ranges for full-term infants. So majority of the neonatologists still are in favor of low oxygen, initial oxygen at the initial phase of stabilization of the preterm babies. However, the most of the interviewed neonatologists acknowledged that evidence was lacking and the further research is needed to get an answer to this question. Is it really important to reach saturation targets during stabilization of the preterm babies? And here, an individual patient data analysis of 768 infants below 32 weeks of gestational age who were randomized either to low or to high initial oxygen concentration at delivery, that infants that did not reach the minimum saturation level of 80% by 5 minutes, they are more likely to have low heart rates, to develop severe grade third 4 intraventricular hemorrhage or to have more chances to die. So the risk of death increased with time taken to reach a minimum saturation of 80%, and infants were less likely to reach saturation of 80% by 5 minutes if respiratory support was initiated with less oxygen. So this clinical trial is in favor of higher oxygen concentration at the beginning in order to reach the minimum saturation target faster in these babies. And another individual patient data from 8 randomized control studies showed comparing the lower and the higher oxygen concentration for the preterm infant resuscitation showed the same, that if the babies did not reach the 80% at the 5 minutes of life, they had more chances to die and more significantly higher chances to have intraventricular hemorrhages of grade 3. So we could have some important messages that almost 50% of infants who are less than 32 weeks do not reach saturation targets at 5 minutes of age. Those who do not reach saturation of 80% by 5 minutes are at increased risk of death or intraventricular hemorrhage, especially when compared to those who exceeded the target. And we still have a question, is the current 5 minute target too low for the babies? Or do we need more oxygen initially to reach the faster this target? And one more recent publication or recent study showed that a secondary analysis of 284 infants less than 32 weeks of gestational age that were enrolled in several derivative trials showed that those who did not reach the saturation level of 80% by 5 minutes of life, they are more likely to die, to develop severe intraventricular hemorrhage, to have lower heart rates, require high mean airway pressures, and were given more oxygen compared to infants with higher saturation levels at that time after birth. I think that's very interesting and also kind of adding some value to this clinical trials I mentioned before is one of the last clinical trials done by an Austrian group of researchers, which is published just a year ago, that the babies, the very preterm babies, had a significantly lower heart rate at the minute 3 and 4. In case if these babies did not reach the saturation target of 80% at 5 minutes at 5th minute of life. And what is also very much important, I think, in this study, the near infrared spectroscopy was used to measure the brain cerebral oxygenation, and this is also showed that neonates in the group which did not reach the 80% had a significantly lower cerebral oxygenation, and probably also the cerebral blood flow compared with the group who has higher than 80% of oxygen of saturation level. So I think that it's not coming out of all clinical trials and clinical studies done. Now we could say certainly that oxygen saturation target ranges are really important for the preterm baby, especially during the first minutes of life. And based on that, the recent publication in Clinics of Perinatology, published by Maximo Venter and Ulla Saustad, is kind of expert suggestions or expert recommendations for the initial oxygen use in the delivery room, that the smaller the baby, the smaller the baby, or the less gestational age is of the baby, the higher initial oxygen saturation we should look for. And of course, when you are talking about the term babies, it's no question now, no discussion that these babies should be, the stabilization of these babies should be started at room air, and the saturation targets at 5 minutes should be higher compared with the very preterm babies. Another point I wanted to go through quite fast. That is I think that's very important point. Also, oxygen during initial stabilization and initiation of breathing or breathing activity at birth. And hypoxia, we know that hypoxia is potent inhibitor of fetal breathing movements before the birth, and this inhibitor effect persists for the days and weeks after birth even. Immediately after birth, hypoxia may inhibit respiratory drive and cause adduction of the glottis. That is also very important issue when you're coming out of initiation of the first breath of the preterm baby. In particular, this is actually for the preterm babies. And on the other hand, hyperoxia could also inhibit the chemoreceptors as a delay or in onset of breathing that was observed in asphyxiated infants, as well as animal studies resuscitated with 100% of oxygen. So, but on the other hand, and another aspect we should keep in mind that very and extremely preterm infants in the delivery room could require higher oxygen fraction, high fraction of inspired oxygen due to inadequate lung aeration, because the surface area for gas exchange is suboptimal due to lung immaturity of these babies. So, and I think that it's was very interesting clinical study was done by Arjen Tepa's group from Netherlands, and they compared initial via low VO2 on breathing efforts on preterm infants. And the main primary outcome was minute ventilation of spontaneous breathing, but also they assessed also tidal volumes, mean inspiratory flow rate, respiratory rate at the first 5 minutes after birth, duration of mask ventilation in the first 10 minutes after birth. But also, to evaluate the presence or absence of oxidative stress, they also checked the level of 8-isoprostaglandin F2 alpha in the blood from the first to 24 hours of birth. And the results, as I mentioned, saturation in the group of the babies who received 100%, they reached the SO2, SpO2 at 5 minutes much faster, and the heart rate in this group of the babies was also higher. But it's interesting that average tidal volume at first minutes of life was significantly higher in the 100 oxygen group of the patient, as well as time of mask ventilation in the first 10 minutes was significantly shorter in this group. The average SpO2 in the first 5 minutes was also significantly high in the high oxygen group, like duration of hypoxemia was significantly lower in the group with the initial high oxygen concentration. At the same time, when looking at the at the oxidative stress markers, there was no significant difference in the groups who received 100% and 30% of oxygen. So, and author's conclusion is that initial stabilization of preterm infants at birth with 100% led to higher breathing effort, improved oxygenation, and the shorter duration of mask ventilation as compared to 30% of oxygen group, without increasing the risk for hyperoxia, or oxidative stress. And summarizing my presentation, I just want to say that optimal oxygen concentration as well as oxygen saturation targets during the first 10 minutes of life in preterm infant is still unknown. Data show that oxygen levels, even with their first minutes of life, have enormous potential to influence death and long-term outcomes. So, in other words, the oxygen saturation targets are very important in these babies, but how to reach these oxygen saturation targets, what should be initial concentration of oxygen is still not very clear. Less invasive administration of the surfactant in spontaneously breathing preterm babies is preferable technique. Also, both bovine and porcine-derived surfactant products are effective in treatment of respiratory distress syndrome in preterm infants. Accumulated evidence shows some advantages for actin alpha surfactant. And further evidence for best practice is needed from large-scale randomized controlled trials to determine not only the short-term but also long-term implications of oxygen during delivery room stabilization of the preterm infants at birth. So thank you very much for your attention. Best regards from Vilnius. And looking forward to see you once see you here once this COVID issue will be ended. Thank you very much.
Thank you, Professor Arunas, for an excellent review. We start with the discussion among the panelists. I'm hoping the participants or attendees will type in their question. In the meantime, I would like to ask, as we are waiting for the questions from the audience, any questions or comments from the other panelists? Because you touched upon oxygen FiO2 threshold yesterday. Professor Corneli talked about 23% or greater may predict CPAP failure. David is here. He can talk about the European consensus guidelines that you talked about. Go ahead, Dr. Arunas.
Yeah, do everybody hears me? Does you hear me?
Yes.
Okay, good. Yeah, I think that Professor Corneli yesterday was talking a little bit different, about a different story a bit. We are talking about initial stabilization of the baby at the delivery suite. And of course, I think that what is important in this case is kind of lung recruitment. We are talking about using CPAP as early as possible, keeping in mind the first breaths of the baby. And I think that it's also is as much important as to discuss what kind of concentration of oxygen we should use. And I think that Virginia yesterday was talking more about when the baby is already on CPAP, and then we are talking about the failure, means how initial oxygen could be predictor, a good or bad predictor on how the baby will be successful on CPAP. I think that's my point of view, and for me, it's clear that we should start as much as possible, as early as possible, to use CPAP at the delivery room. Of course, combining the surfactant if it's necessary, and oxygen and oxygen saturation targets. They should be kind of indication for us how active or how proactive we should be in delivery room using CPAP as well as surfactant maybe later on after the first steps of stabilization of the baby. David?
Thanks, Arunas. I enjoyed your talk as usual. I just wondered, have you any recent thoughts on the method of delivering very early delivery room CPAP? We've seen this new information coming through from Ariane De Pass's group about the effects of applying a face mask, perhaps inducing apnea. And I wondered, we've been playing around with RPAP for stabilization, which is just nasal prongs right from birth. And obviously in Austria, Katrin's group just used a nasopharyngeal tube for CPAP. And have you any thoughts on how we should be guiding people to manage very early respiratory support in terms of this new information that's coming along about the potential negative impact of face masks being applied?
You know, I don't have clear answer to that. Being you know, honest. Actually, we are trying to use we are using different devices in the living room, like Benveniste valve system, as well as infant flow system. And I don't see that, but of course, mainly using the nasal cannulas if possible. But well, it also depends. I think that it also very much depends if the baby has any breathing efforts or not at all. If the baby is not breathing at all, I don't think that it's kind of reasonable to put the nasal prongs into his nose. At the beginning, you should start something to do that the baby would start breathing, and then as soon as the baby starts breathing, probably then you could think about what the best way to apply CPAP, nasal CPAP for him, either through nasal cannulas or via the nasal and mouth mask. But I don't think that at least I don't know if such kind of clinical trials have been done ever. For me, it's important that the CPAP would be applied as soon as possible. I don't think that the device or the devices really plays the major role, but could be I am wrong.
There is a question in the Q&A box, Arvidas. It is in Russian, I think. So
okay, I will
look at that in the Q&A box. In the meantime, could I ask the other panelists to make any comments?
I'm trying to find where it is.
See at the bottom says Q&A, and then there's one. When you go on the bottom.
Okay, I see it.
Yeah. We have 2 more minutes.
Okay. The question is, could we give for preterm babies during the first minutes of life, could we give the oxygen more than 50%? I think that yes, why not? It depends also how when you are starting the stabilization of the baby during the first 5 minutes of life, and you should follow how the baby's saturation is going up. If you at the 5 minutes, if you are far away from the level of 80%, of course you have to increase oxygen concentration. It is not a question means kind of what is a maximum upper limit of oxygen. It's a question that you have tried to reach this saturation target of 80% as soon as possible. And if you need 100%, you use 100% for the short time. And as soon as you are reaching oxygen saturation target, then you can decrease slowly but steadily, controlling by pulse oximeter. That's my answer.
Great. I think, perfect. We are on time. So actually the next 2 talk speakers, Professor Danielle and Professor Peter, will be talking about the update on 2020 neonatal resuscitation and gaps in our knowledge. So let's get to the talks.
Hello to everyone, and thanks for inviting me to the 2021 edition of the Neonatal Perinatal Medical Forum. I have not conflict of interest to declare, and I am from Italy, from Padua. Padua is a city in the northeast of Italy, closer to Venice. Venice is more famous than Padua, but Padua is famous because it's one of the oldest university in the world. It has been established in 1222, and on the next year we have the 800 year anniversary, and so it's a very important anniversary for us. If you can in Padua, you can see the university building, where you can find the oldest anatomical theater in the world, and also you can find you can visit the podium of Galileo Galilei. Galileo Galilei spent 18 years in Padua, and so it's an important city also for this aspect. And if you can in Padua, you can find also this in the university building, you can find this monumentum. Here you can see the Elena Lucrezia Cornaro Piscopia. She was the first woman in the world to be awarded a university degree in philosophy. And so, just to show you the open mind at the time of the University of Padua. Coming back to the topic of my presentation, here you can see the history of guideline for neonatalization. What happened before 1960 was based on empirical observation. We went in the living room, we performed the procedure, we saved the patient, we wrote the paper. Of course, in the last years, the situation changed, and we tried to have a scientific approach to the neonatalization, to the neonatal management of the newborns at birth. And you know that since 2000, in the last 20 years, every 5 years, a new edition of the guidelines on neonatalization has been published. Last October, the last edition, the 2020 edition, has been published. Here is the group of the ILCOR, the task force of the neonatal task force of the ILCOR group that has a specific task. The task of the ILCOR neonatal task force is not to prepare the guidelines, but is the task is to prepare a specific document. That is the consensus on science. This document the task or the contents of this document is the revision of the available literature in all the peak of question on neonatalization, and to produce the treatment recommendation. And so I think that is a very important document. When I think to the guidelines on neonatalization, I think a tree, where the roots of the trunk is the consensus on science and the treatment recommendation. That is the most important document, where you can read, you can find the evidence, you can find the treatment recommendation, you can find also the gap of knowledge. And in this tree, the fruits of these trees are the guidelines of each country: European, American Heart, Brazilian guidelines. Every part of the world use as a basis the consensus on science. Another new of the last edition of the guidelines of the ILCOR process is that in the past, every 5 years, the consensus on science, the guidelines were published at the same time, every 5 years. Why? In the last period, in the last 5 years, the ILCOR recognized that the knowledge is a continuous process. And so we can produce consensus on science not only every 5 years, but also during the lapse of time. So it is this time period. And so if you look at the last 5 years, 3 consensus on science for neonatalization have been published. They regard initial oxygen for preterm infants, and one referred to the management of infants born through meconium stained amniotic fluid. At the end of 5 years, last October, the consensus of science, the summary of consensus on science available and guidelines have been published. In this slide, you can see the top 10 take-home messages for neonatalization life support published in circulation to 2020. And honestly, there are only few changes from the edition 2015 to the 2020 edition on guidelines on the neonatal station. Another news of the last edition guidelines on the neonatal guidelines regard the color. You can find the color in this edition. The color means the strength of recommendation, and the color has to be considered like a traffic light. If you see the green color, it is a class 1 strong recommendation, and so it has to be down. It should be down. If you see a red color, it means harm, strong recommendation for harm, and so it has not. It should not be down. You have to avoid it. In the between, you can find the yellow or orange color, where you have a moderate evidence. We start with the change between 2015 and 2020 algorithm. The algorithm did not change in this new edition, so we have not new aspect to consider. Or preparation remained the same. As you can see here, the class of recommendation is green, and so it should be down. At least one person has to be present. We have to consider risk factors. There are different tools that you can consider, you can refer to, but please, the history of the woman is very important. The equipment, the preparation of the equipment is an important aspect of the preparation, and the team briefing is confirmed also in this edition, as we did in the 2015. Initial step. For the initial step, two important aspects regard the temperature and the heart rate assessment. For prevention of thermal loss in the delivery room, we have different approaches, a different thing to do. The first is to have an appropriate delivery room temperature. You know that the temperature of our delivery room has to be between 23 and 25 degrees Celsius. We have to use the infrawarmer. Not all the infrawarmer are similar. In this study, we demonstrated that there are important differences among the available among the infrawarmer available in the market. We could consider to use exothermic mattress. We have to cover the head of the baby with a cap, possibly with a woolen cap. We have to wrap the baby with a plastic bag of wrap, and we could consider the use of humidifier and heated gases. More than the single intervention, the combination of intervention is very important. In this last edition, also the plastic bag in low resource setting, not only for very preterm infants, but also for babies late preterm or full term could be considered, because it has been demonstrated that the plastic bag also in this group of patients could be effective in a low resource setting. This study, the name is Scopely study. We try to understand if the use of servo control system in preterm infants could be useful in the delivery room. And so we randomized 450 patients. A part of them, half of them were randomized to be treated with the servo control system, and half of them to be treated without servo control system. In this study, we enrolled only very low preterm infants, and so with the birth weight less than 1.5 kilograms. The primary outcome of this study was the temperature and milk emission in the normal range. And as you can see here, no differences were found between the group that was treated with the servo control compared to the with the group that was not treated without servo control. And So no difference for the primary outcome, where we found a difference for mild hypothermia. Mild hypothermia was more frequently found, 32% of the group, in the servo control system compared to the group without servo control system. The conclusion of this study that has been published last month was that in very low birth weight infants, thermal management with servo control system conferred no advantage in maintaining normothermia immediately after birth, while it was associated with increased mild hypothermia. Thermal management of preterm infants immediately after birth remained a challenge. As you saw, only 40% of very low birth weight infants in 15 Italian centers, level 3 Italian centers, had a normal temperature at initial admission. The second aspect of initial steps regards the heart rate. We know very well that heart rate is the most important indicator of neonatal resuscitation, of the resuscitation in general. And for this reason, we have to check the heart rate 4 times during the first 2 minutes of life. This is the American algorithm. This is the European guideline. We recommend to check 5 times the heart rate, 5 times during the first 2 minutes of life. How can we assess the heart rate? Heart rate can be assessed with umbilical cord palpation. We can use a stethoscope, and so we do auscultation, or we can use a 3-lead electrocardiogram. The guideline 2020 recommended to use the stethoscope because it is better than umbilical cord palpation. Umbilical cord palpation gives you a wrong information on the heart rate more or less half of the time. The guideline 2015 suggested that 3-lead electrocardiogram could be better than auscultation. Here you can see the treatment recommendation. In babies requiring auscultation, we suggest, so we don't recommend, we suggest electrocardiogram can be used to provide a rapid and accurate estimation of heart rate. It was a very weak suggestion, very low quality of evidence, because we suggest it can be used. Please make attention to the words. However, based on this treatment recommendation, many centers around the world, many hospitals started to use the 3-lead electrocardiogram. This is a study from Oklahoma Hospital in the US, and they showed that they started to use the electrocardiogram in the delivery room, and they found that after this intervention, after this implementation, there was a significant increase, 3.5 times, of chest compression in the delivery room. We have to know that chest compression, if the patient has a good heart rate, is not a good thing to do, because we obstaculate the ventilation and also the heart function. The assessment of heart rate was one important research topic in the last 5 years. In this review article, Johnson et al. Reported 10 ways to evaluate the heart rate. However, what the guidelines to 2020 recommend that for electrocardiogram, and you can see here that the color is red and so should be down, during chest compression, electrocardiogram should be used for rapid and accurate assessment of heart rate. Okay, and so not in all neonatal resuscitation, but only when we have an advanced resuscitation during chest compression, the electrocardiogram should be used. Stimulation, tactile stimulation is reasonable, is another consideration to do, but the next question is, how can we do the stimulation? What is the most effective modality to stimulate the baby? You know that the textbook of neonatal resuscitation recommends 2 modalities. We can stimulate the baby by using a back rubs, or we can do the foot flicks. In this study, we randomized 186 patients, not crying infants. This study was conducted in Africa, in Uganda, in hospital in Uganda. Half of them, of these patients, not crying infants, were randomized to receive back rubs, and half of them were randomized to receive food flicks. What we found was that success of stimulation, that was no need for positive pressure ventilation, was 82% in the back rubs group and 73%. This was 99% different, but it was not significant. And also the time to the first cry was not different between the two groups. And so it seems that there is a signal in favor of back rubs, but this signal is not significant. Mechanical inspiration syndrome. We know that in 2015 edition, endotracheal intubation and suction was not suggested for non-vigorous infants because insufficient evidence to continue tispatic. In 2020, we have the same recommendation, no benefit. Laryngoscopy with or without tracheal intubation suctioning is not recommended. But what happened between 2015 and 2020? We have more evidence. We have, in 2015, we have only one study, the CAPI study, but in the last 5 years, other 3 studies, randomized control studies, were published. And you can see here that if you do the suction or we don't do the tracheal suction, we don't change the outcome of mechanical aspiration syndrome, and we don't change the survival discharge. This study have been conducted in India, where the incidence of mechanical aspiration syndrome is significantly higher than in our countries. Oxygenation. 2020, for oxygenation to initiate resuscitation in near-term or full-term infant. 2020, 2015 recommended to start room air, and again 2020 confirmed this position. If you have a full-term or near-term, we start positive pressure ventilation in room air. What about preterm infants? In 2020, the recommendation was start between 30 to 90%. 2015 was start with between 21 and 30. What happened in the last 5 years? This study, it is the Torpedo study. It was a randomized control trial. They enrolled patients with a gestation age less than 32 weeks. And patients were randomized to be resuscitated with initial oxygen, 21% or 100%. Of course, the target were changed. The oxygen supplementation was guided based on the saturation target immediately after birth. However, this study showed that no difference were found. It was an interim analysis. No difference were found for mortality in the entire group, if you start with room air or 100% oxygen. But in the subgroup of 28 weeks, they found that the mortality was significantly increased in the group that was treated with room air compared to the group that was treated with 100 oxygen percent. And this difference was significant. And for this reason, the study was stopped for harm. And so this study, the Torpedo study, suggests or show that room air is too low. Otherwise, we know that 100% also is too high, because this review and meta-analysis showed that severe neurodevelopmental impairment and the language less than 70 is significantly increased when we start with 100%. So no 21 and no 100%. These are the conclusion of the review and meta-analysis published by the ECOL group in pediatrics at the beginning of 2019. The ideal initial FiO2 for preterm newborn is still unknown. Also, the majority of newborn less or equal 32 weeks gestation will require oxygen supplementation. We know that if you start 21, the most part of them, more or less 85%, will need oxygen. I like the SOCSTAR or SOCSTAR recommendation of for initial FiO2 during the naturalization. If you have a term near 10 infants, the odds ratio for mortality is 0.69 and the confidence interval is less than 1. And so we have a clear advantage in favor of fair. And so start with room air and adjust according to saturation. If you have a preterm infant with a gestation age between 28 to 31, the odds ratio for mortality does not change, and so start with 21, 30% oxygen. If you have a preterm infant less than 28 weeks gestation, the odds ratio for mortality is significantly higher, 5 times higher, and as you can see here, the confidence interval is higher than 1. And so if you have a patient with less than 28 weeks, don't start with room air, but start with 30%. Another very important suggestion by Ola Sosta is that it is important the initial oxygen concentration, but more important probably is the saturation of our patient at 5 minutes of life. And so we have to try. The goal is to put the saturation, to achieve the saturation of 80-85% at 5 minutes of life. What the guidelines recommend 2020 is to start in the preterm infants with 21-30, and the harm should not be down. 100% oxygen should not be used because it is associated with excessive mortality in term and late preterm infants. If you want to come back to previous slide, as we show you, 2020, 2015, and 2020, the recommendation for preterm infants remain the same. Start between 21 and 30%. These are the American guidelines, and the saturation has to be higher than 80% at 5 minutes of life. These were the American Heart and American Cardiopediatric guidelines. This is the European guidelines. In 2020, the European guidelines are aligned with the SOCSTAR recommendation. And so if you have a patient less than or equal to 28, we start with 30%. If you have a patient with a gestation age between 29 and 32 weeks, we start between 21 and 30%. Again, saturation at 5 minutes is important. Ventilation. Is it better to use a TPs or is it better to use a self-infecting bag? In 2015, the treatment recommendation was there is insufficient evidence so that a recommendation of one device over another will be purely speculative. What we have is what this recommendation was based on 2 studies that were available at the time. This was the study by Jennifer Dawson that showed that in patients with gestation age less than 29 weeks, sorry, there were no differences in saturation during the first minute of life if you start with a TPs or if you start with a self-inflating bag. The second study available at that time was this study. It was a study, it was a multi-center, multi-country study. 500 patients were randomized to be treated with TPs and 500 were randomized to be treated with a self-inflating bag. The inclusion criteria was a gestational age higher than 26 weeks. And this study found that the primary outcome of the study was the heart rate at 2 minutes of life, and no differences were found for the primary outcome. So if you start with TPs of your self-inflating bag, we don't change the heart rate at 2 minutes of life. However, there was a significant decrease in intubation, incidence of intubation in the group treated with the TPs compared to the self-inflating bag. And in addition, we found also the TPs group receive lower maximum peak inspiratory pressure. In this group, in the same study of very low birth weight infants, there was also a decrease in the incidence of PPD. This was we had available in 2015. What happened between 2015 and 2020? Another scoping review has been published in 2020, and this scoping review identified new study, new evidence for conducted official official review and meta-analysis. Last week has been published in the ILCOR website, and you can find it there. The consensus on science with treatment recommendation for devices for administration for administering positive pressure ventilation at birth. And so please go and add a comment, because now it's open for public comment. However, if you have a TP, so you have a self-in-black, probably we can consider to use the TPs. The next question is which TPs we can use. There are, in this study, this is a benchtop study conducted by the group of Sydney, by Hinder et al. And they found that not all the TPs are similar. They compared 5 TPs available in the market. And what they found was that if you set a peak at 20 centimeter water, a part of them maintain the given 20 centimeter water of peak inspiratory pressure, but as you can see, a part of them give a higher inspiratory pressure. If you set 5 centimeter water as PEEP, as you can see here, a part of this TPS devices available in the market gave a higher peak compared to the peak that we have set. And so please try to consider which is your TPS. Inspiratory pressure for preterm infant, the American Heart, American Cardiopediatric recommend, as they did in 2015, initial inspiratory pressure between 20 and 25 centimeter water. The European guidelines instead recommend a higher inspiratory pressure between 25 and 30. If you come back to the guidelines, the class of recommendation green is one here. PPV should be provided without delay if a patient is in need, and another harm here on the other side, the red color, excessive peak inflation pressure are potentially harmful and should be avoided. Sustaining an inflation. In 2015, the guidelines suggested against the sustained line inflation. In Italy, we were very motivated. The sustained line inflation was very popular. In this study, we demonstrated that 65%, 3/4 of Italy, level 3% in Italy, were using the sustained line inflation routinely in preterm infants. And so it was very popular procedure in Italy. What happened between 2015 and 2020? We were very interested in the result of the SAIL trial, the study that randomized patients between 23 and 26 weeks to receive sustained line inflation or standard treatment. And the study has been published in JAMA 2019. And what they found was no differences in the interim analysis between the two groups for the primary outcome, that was death or bronchopulmonary dysplasia. But if you look at the mortality rate within the first 2 days of life, this was significantly increased in the group that received sustained line inflation compared to the standard resuscitation. This study was stopped for harm, and the recommendation of the guideline 2015, here you can see the red color, harm, use of sustained line inflation to initiate the station is potentially harmful and should not be performed. Okay, so we recommend, the guidelines recommend against the sustained line inflation. Laryngeal mask. What happened between 2015 2020? A Cochrane review has been published. It included 7 randomized control trials, almost 800 patients, even if the evidence was, the quality of evidence was very low to low. This meta-analysis showed that if you start with the laryngeal mask compared to the face mask, you significantly reduce the need for intubation. If you start with the laryngeal mask instead of face mask ventilation, you significantly reduce the ventilation time. You know that the laryngeal mask appeared for the first time in 2015 in the algorithm, and so it has been confirmed also in 2020. Another important study that has been published last November on the use of laryngeal mask during attestation. And in this study, we enrolled a patient with 34 weeks or 2 kilograms of birth, and they were in need of positive person ventilation. The study was conducted in Kampala, this large hospital in Kampala, in Uganda, and after the approval of ethics committee. Patients were randomized to be treated with it was a day-by-day cluster randomization. Patients were randomized in need of resuscitation, were randomized to be ventilated with a laryngeal mask or with a face mask. The primary outcome of the study was not the time of intubation, time of ventilation or need of intubation, but was early neonatal deaths within 7 days or admission to NICU with moderate to severe hypoxia ischemic encephalopathy at day 1 to day 5 during hospitalization. We randomized 500 patients in the LMA group and 500 patients in the face mask group. And what we found was the primary outcome did not change between the group, 27%, 24%, and also the secondary outcome were similar between the 2 groups. The conclusion of this study were in neonatal asphyxia. The laryngeal mask was safe in the hands of midwife, but was not superior to face mask ventilation with respect to early neonatal deaths and moderate to severe hypoxia ischemic encephalopathy. Cord clamping, we have almost finished. When we are in the delivery room, we have 3 approaches. We can do the immediate cord clamping, we can do the delayed cord clamping, or we can do umbilical cord milking. Really, there is a four intervention that is physiological delayed cord clamping, but in general, we have the significant is more linked to this aspect. And 2010, so it is 10 years that delayed in umbilical cord clamping for at least minute is recommended for newborn, not require resuscitation. So if you have a patient not require resuscitation, it is well known that we have to wait at least 1 minute. For patients in need of resuscitation, we don't know what is the recommendation now. So we have not enough evidence to suggest, to recommend a specific approach. Delayed cord clamping is so immediate cord clamping for patients who don't need the resuscitation is contraindicated, is red. Why we have to do the delayed cord clamping. What about the milking? For the milking, in 2015, we suggest against the routine use of cord milking for infants born less than 29 weeks gestation. The reason was that there is not evidence for improvements or safety of long-term outcome. What happened between 2015 to 2020? This randomized control trial. The PICO question was infant with gestational age less than 23 weeks, or between 23 weeks and 31 weeks. The intervention was thus umbilical cord milking. The comparator was delayed cord clamping, and the outcome was intraventricular hemorrhage or death. This study, if you look at the primary outcome, there were no differences between the 2 groups, but if you look at the incidence of severe intraventricular hemorrhage, we can see that it was significantly higher in the group that received umbilical cord milking. This study was stopped at the interim analysis due to harm because there was a significant increase of severe intraventricular hemorrhage. What the guidelines recommend in this case is based on this study by Katiria, Dr. Katiria, is umbilical cord milking not recommended in patients with a gestational age less than 28 weeks. Ethics is the last part of my presentation. What was the recommendation in 2015 for patients? We suggest that in infants with APGAR score of 0 after 10 minutes of resuscitation, if the heart rate remains undetectable, it may be reasonable to stop assisted ventilation, okay, after 10 minutes of life. What about the guideline 2020? In this study, Elizabeth Foglia look at the discontinuing the resuscitative effort. And which is the outcome of the question of this study, of this review, was which is the outcome of newborn immediately after birth presented with at least 10 minutes of asystole, bradycardia, or pulseless electrical activity for which CPR is indicated. The individual analysis, 16 study, and this review, and what they found was that survival without moderate or severe neurodevelopmental impairment was 37% for survivors, and was 20% for all enrolled in this study. So it was, despite the severe situation after birth, the survival without moderate or severe neurodevelopmental impairment was acceptable. And so the important change in the guidelines, these are the European guidelines, is heart rate of a newborn if a newborn term infant remain undetectable for more than 20 minutes after birth, despite the provision of a recommended step resuscitation and excluding reversible causes, discussed with the clinical team and family and consider stop resuscitation. And again, the guidelines 2015 recommend to consider stopping resuscitation after 10 minutes, but in this new edition, the changes, the recommendation is a change in goal of care. Is not stop resuscitation, but change goal of care after minutes of not responding resuscitation. This is green color. In conclusion, the ILCOR task force evaluation is a standardized and continuous process. Guidelines are based on ILCOR consensus on science. Hypothermia and hyperthermia are associated with mortality and morbidity, and so should be avoided with the modality that we have seen. Immediate laryngoscopy and the suction is not indicated in depressed infant with meconium stadium amniotic fluid. Low oxygen concentration seem reasonable, but saturation target 5 minutes is the goal. Sustaining line inflation is not recommended. Delayed cord clamping after breathing seems to be the best choice. So please, if a patient does not need the resuscitation, wait and give him the time for optimizing the transfer of blood from the placenta to the baby. Milking is not recommended in infants less than 28 weeks, and if a rate of a newborn term infants remain undetectable for more than 20 minutes, consider stopping resuscitation. Thanks for attention.
Thank you so much, Professor Daniel. So we'll listen to Professor Peter Reynolds talk, and then Dr. Boris Kramer will moderate this session. Boris.
Okay, So the next presentation is by Dr. Peter Reynolds from the United Kingdom, and he will go into the new guidelines and the new ideas we have on the therapy with caffeine. So for those who are early in the morning, like Ram in California, and those who are in the middle of the day, like myself in Central Europe, I'll help myself to a coffee. Peter, please go ahead.
Hello there, my name is Peter Reynolds. I'm a consultant neonatologist at St Peter's Hospital in the UK, and I'm talking to you today on the subject of caffeine in modern neonatal care. And this is an update talk, and I'm very grateful to Professor Ramanathan, the organising committee at the Neonatal Perinatal Medical Forum, for inviting me to do this talk. And I'd like to thank the coordinators and also Chiesi Pharmaceuticals for all the support that they've given to date. So in terms of updating about caffeine, I'm just going to cover a few areas that I think are interesting. The first is a little reminder about the pharmacology and the mechanisms of caffeine in the preterm newborn. Then I'm going to cover the use of caffeine in clinical care and cover some of the areas that are distinctly uncertain. Talk about how caffeine influences important clinical outcomes in babies, and then try and deal with some of the typical controversies that exist around caffeine, and finishing up with some advice for developing your own guidelines locally. So on to the pharmacology and mechanisms of caffeine, or to give it its chemical name, 1,3,7-trimethylxanthine. Caffeine is distributed very quickly in the human body. It's got a similar molecular structure to adenosine, and its pharmacokinetics are not affected by the route of administration. It's a hydrophobic molecule, so it passes through biological membranes easily, and it distributes rapidly in the body without tissue accumulation. After oral or intravenous administration, there is almost complete bioavailability, and it's rapidly absorbed from the GI tract with minimal first-pass metabolism. Caffeine normally achieves peak plasma concentrations within an hour of administration, and the CSF levels in preterms are the same as the plasma levels. Caffeine has a long half-life. It is mainly eliminated early on in the neonatal period by renal excretion, and then there is biotransformation in the liver through cytochrome P450, and partially by xanthine oxidase, and the metabolism is something that increases with maturity and is regardless of birth weight or gestational age of delivery. Females metabolize caffeine at a higher rate than males, but there is a long serum half-life quoted anywhere between 60 and 140 hours in the preterm infant. Caffeine is known as a competitive antagonist of adenosine receptors, particularly adenosine A1 and adenosine A2A receptors. And through this, it has a number of effects, including increasing respiratory drive and also some anti-inflammatory responses as well. And these are considered to be important when we think about the improved outcomes associated with caffeine. I'm sure you know this, but caffeine has multiple mechanisms of action. If we consider the brain, caffeine is associated with increased neural activity and responsiveness to carbon dioxide, with reductions in hypoxic breathing suppression and anti-inflammatory neuroprotection. Caffeine also has a positive impact on myelination and maturation of oligodendrocytes, and has anti-apoptotic effects. Within the respiratory systems, caffeine improves diaphragmatic contractility and reduces pulmonary inflammation. It also has a diuretic effect, which is mediated via the kidneys, but has a positive impact on breathing. And cardiovascularly, it increases the left ventricle stroke volume and has inotropic and pressor effects as well. It also has effects on other outcomes such as ROP, and this is some interesting work which was published in 2019 looking at neonatal rats and their proteomic profile specific for ROP, showing that in neonatal rats with retinopathy compared to controls, there were changes in the proteome associated with the caffeine-treated population. Caffeine does have anti-inflammatory effects, but there are some concerns that at high doses it may be pro-inflammatory, and this was some work published in 2011 in 26 babies less than 30 weeks, showing various changes in cytokines. Across the 4 panels, you can see that at higher levels of caffeine, there were increases in TNF-alpha, interleukin-1 beta, and IL-6, and a corresponding decrease in the anti-inflammatory interleukin-10. So these effects need to be considered, but equally at normal caffeine levels, there was suppression of these inflammatory cytokines. So moving on to the clinical use of caffeine, I think we would all agree that caffeine is the standard of care when we are aiming to treat apnea of prematurity. There has only really been one trial which has addressed both the short and the long-term outcomes, and that was the CAP trial, which was published in 2006. This had 2006 infants with a birth weight between 500 and 1250 grams who were less than 10 days old and were randomized to either receiving placebo or caffeine treatment. The outcomes showed that caffeine started within 10 days of birth reduced the need for subsequent respiratory support. And these effects, along with reductions in bronchopulmonary dysplasia and significant PDA, accounted for just over half of the primary neurological outcome improvements that were seen at 18 to 21 months, implying that there was a direct effect of caffeine on neurological improvement as well. You will be familiar with many of the CAP study outcomes, and this is a study that went on to follow babies not only at 18 to 21 months, but also through 5 years and to 11 years. And even at 11 years, there were statistically significant differences between the caffeine-treated group and the placebo group in terms of motor function. Again, implying that caffeine has long-lasting effects, either directly or indirectly, on the outcome of these premature babies. So when should we start caffeine? So in the CAP trial, the median age to start was 3 days. And in babies who started caffeine within 3 days, they showed shortened periods of requiring respiratory support than those who started treatment later. Another analysis done in 2014, published by Dobson, looked at a large population of babies retrospectively, showing that a smaller proportion of babies died or survived with BPD if caffeine had been started early compared to the population where it had been initiated later on. And these give some evidence to early treatment being beneficial. In fact, there's quite a lot of studies, and I'm not going to go through all of these, on early versus late caffeine. But rest assured, you can see that between 2010 and 2017, there were quite a lot of studies, some cohort analyses, and some randomized controlled trials, and some systematic reviews that have looked at these effects and generally showed reductions in death, reductions in BPD, PDA, and in some cases intraventricular hemorrhage in babies started on early caffeine. In terms of meta-analysis, there seems to be some evidence that early caffeine is associated with improved outcomes. This was some work published by Peter Davis that appears to show for some important outcomes, such as death or major disability, cerebral palsy, BPD, and treatment required for PDA, that the early use of caffeine was associated with improved outcomes. So bearing all that in mind, here's a clinical scenario. You are managing a 24-week infant with no antenatal steroids on board. The baby has been intubated in the delivery suite and a dose of surfactant has been given. The baby is brought round to the neonatal unit and umbilical lines are placed. It is now day 2 and the baby remains on mechanical ventilation. The FiO2 is still 45% and X-rays show evidence of severe RDS and further surfactant is given. The clinical decision is to maintain mechanical ventilation for the time being. One of the junior staff has read that caffeine reduces bronchopulmonary dysplasia and therefore asks, should we start caffeine even though this baby is going to stay on the ventilator? So the question is, do we have good evidence to support the use of, or in babies who are ventilated for starting caffeine? And the answer is not really. The CAP trial didn't control for the clinical indication nor the type of respiratory support in which babies received caffeine. Furthermore, infants may have met the eligibility criteria for CAP earlier because they were less sick. In other words, they weren't ventilated or they were about to be extubated. CAP is also now quite an old study. The babies were enrolled between 1999 and 2004, and our neonatal practices have changed substantially, and we are ventilating for shorter durations and ventilating less overall as well. There have been a couple of observational studies published from a couple of networks that showed lower rates of BPD in early caffeine groups, but again, the group who received caffeine later appeared to be sicker. This study was published in 2018 and is a study around the use of early caffeine and weaning from mechanical ventilation. Now, this study was stopped early due to an apparent excess of deaths, and I've just highlighted some of the results because they're quite interesting. There was no significant difference between the early caffeine group and the control group in terms of BPD. Both groups actually received caffeine after the first successful extubation, so the only differences were that the group of the early caffeine group in 41 babies received caffeine at an early point, but this did not reduce the age of that first successful extubation and did not speed up the weaning from mechanical ventilation. Nor were there any differences in secondary respiratory outcomes. If you look at the smaller table at the bottom, you can see that there were differences in necrotizing enterocolitis between the groups, but these were not significant. And there were differences in IVH, but again, they were not significant. But nevertheless, despite a non-significant difference between the groups, the trial was stopped early. Looking at the populations of these groups, they were also quite different as well. There was a statistically significantly higher male proportion in the early caffeine group, and the APGAR scores were different, although this was non-significant. Furthermore, the age of randomization was quite late and might not really meet the criteria of early, as some of us might understand it. All the babies in this study were intubated for surfactant administration and were routinely ventilated. And again, this may not be the sort of practice that many of us would now undertake. And the mean duration of mechanical ventilation in both of these groups was 30 days, which again, we would take to be quite a prolonged period of ventilation. So it's very difficult to draw too many conclusions from this paper, especially as the control group may have had a survival bias. A systematic review looking at early versus late caffeine again seemed to indicate that early caffeine favored outcomes, gave favorable outcomes to things like BPD, but was not statistically significant for mortality, for PDA, nor brain injury. But nevertheless, the duration of mechanical ventilation in retrospective cohort studies definitely is reduced and favors the use of early caffeine in terms of reducing ventilation days. So should we use caffeine routinely in ventilated babies? Based on the available evidence, I don't think that we can necessarily recommend this. There is contrasting data on the effect of early caffeine initiation. It's very hard to distinguish the outcomes of babies who were loaded with caffeine for a planned extubation versus routine initiation of caffeine regardless of the intention to extubate. And therefore, in terms of improving outcomes, the important thing appears to be making a decision to extubate as early as possible and then using caffeine to optimize the chances of success. Here's another clinical scenario. You're managing a 24 plus 5 week infant and antenatal steroids have been given. You're able to start non-invasive respiratory support in the delivery suite and the baby comes to the unit where lines are then placed. Surfactant is given by less invasive surfactant administration administered via a fine tube because an FiO2 reached 30% and it is now day 1. The baby is still being non-invasively respiratory supported and is in air. Should you routinely start caffeine in this case? So there's quite a lot of evidence that very early caffeine improves breathing efforts. And this is an interesting paper that you may have seen published in 2017 by Decker, where they randomized 30 babies between 24 and 30 weeks to receiving caffeine in the delivery room given within 7 minutes of birth, or to receive it later at 48 minutes in the NICU. Now, we would consider both of these to be quite early, but nevertheless, these showed significant differences between the minute ventilation with the blue bar shown for the delivery room and in the tidal volume of breathing as well. So there's evidence that caffeine can exert positive effects on breathing very early on if it is given in this way. This was another paper, another double-blind randomized controlled trial of babies under 1,200 grams who were spontaneously breathing at 24 hours of age with a primary outcome of incidence of apnea. This was a small study with only 26 in the caffeine group versus 26 in the placebo group, but nevertheless, for that primary outcome, showed a significant reduction in apnea, in bradycardia, and in cyanosis, and also a significant reduction in chronic lung disease as well. There was nearly a significant reduction in the need for CPAP as well. The most immature babies in this study showed the greatest effects on the incidence and severity of apnea, which doesn't really come out in these tables. So it's an interesting observation, but it is a small study. Back to the CAP trial. Nearly 2/3 of the babies in the CAP trial were recruited for prophylaxis or treatment of apnea. So this may help to answer our clinical scenario. We know from the CAP trial that treatment with caffeine reduced the need for respiratory support, and that's defined as intubation, positive pressure ventilation, or the use of supplemental oxygen, and this was statistically significant compared to placebo. So should we routinely use early routine caffeine in babies who are receiving non-invasive respiratory support? Yes, there appears to be evidence to support this practice, but it is low-grade evidence. It can, of course, be argued that waiting to treat apnea of prematurity with caffeine would be a more evidence-based approach than giving prophylaxis for apnea of prematurity. However, given the prevalence of apnea of prematurity in extremely preterm infants, this purist approach is often replaced by a pragmatic one. I'm not sure that we would want to wait for babies to suffer a hypoxic episode before starting caffeine. And if you go back to the slide looking at the various mechanical and other effects of caffeine, there are other potential advantages that aren't just centered around apnea of prematurity. The most recent European consensus guidelines, which I'm sure you're well familiar with, state that we should aim to minimize the time that babies spend on mechanical ventilation, and we can use caffeine to do this. So in addition to using volume targeted ventilation and using non-invasive respiratory support techniques and a degree of permissive hypercarbia, caffeine is included in that approach to the overall strategy. Early caffeine should therefore be considered for babies at high risk of needing mechanical ventilation, such as those on non-invasive respiratory support. So if we're going to start caffeine, what dose should we start at? Well, again, there have been numerous studies, and I won't go through these, comparing loading doses and maintenance doses, both high and low. Some of the loading doses as high as 80 milligrams per kilogram, with maintenance doses as high as 20 milligrams per kilogram per day. And interestingly enough, many of the studies with the higher doses showed reductions in apnea of prematurity, and some showed improvements in other important outcome measures, such as general quotient, as well as reductions in BPD and other important outcomes, such as mechanical ventilation. What dose of caffeine should we use? Well, the CAP trial used a loading dose of 20 milligrams per kilo with maintenance of 5 to 10 milligrams per kilo, and a retrospective analysis of the CAP trial showed that lower doses, less than 7.9 milligrams per kilogram, seemed to be associated with more clinical interventions. There was a study published in 2011 looking at caffeine in terms of its effect on development, temperament, and behavior. And this looked at 287 babies less than 30 weeks who were either loaded with 80 milligrams per kilo of caffeine with a maintenance dose of 20 milligrams per kilogram, or a loading dose of 20 milligrams per kilogram and a maintenance dose of 5 milligrams per kilogram. The high dose group showed statistically significantly fewer apnea of prematurities episodes, and also a higher general quotient, and they showed no significant adverse effects on temperament, behavior, or other effects that were recorded. Another study of 218 babies looked at early high-dose caffeine, and again in the high caffeine group there were fewer apneas of prematurity episodes and a higher general quotient as well. And a pilot randomized study in 74 babies again showed in the high dose caffeine group that there were greater incidence of cerebellar hemorrhage. And this report caused great concern because it seemed to show a threefold significant increase in cerebellar hemorrhage in the high caffeine group. So what dose should we use? Well, there is evidence that higher doses of caffeine may be more effective in reducing apnea of prematurity and BPD. And there may be some evidence in improvement on general quotient. However, concerns about serious side effects such as cerebellar hemorrhage need to be considered. Furthermore, we only have the CAP study that has given us genuinely long-term outcome and safety data, and therefore at the moment, the recommended dose needs to be the same as that study, which is a loading dose of 20 milligrams per kilo and a maintenance dose of between 5 to 10 milligrams per kilogram. This maintenance dose should be started 24 hours or more later after the loading dose has been given. And because of the long half-life of caffeine, this allows us to standardize the timing with ward rounds or with other medications as well. It may be justifiable to use higher doses, such as a maintenance dose of 15 or even 20 milligrams per kilo in individual cases. We must be vigilant for the potential side effects of caffeine, which may indicate toxicity, such as tachycardia, agitation, excessive diuresis, or gastric effects, such as vomiting. Serious side effects appear to be very rare, but arrhythmias and seizures have been described. So we've decided to start our caffeine and we've chosen our dose. So how do we continue it? Well, when should we switch to oral caffeine? Should we increase the dose or decrease the dose as time goes on? Is it important to have stable levels as the baby matures and apnea of prematurity becomes less frequent? When should we stop caffeine? And how long should we monitor babies for apnea after caffeine is stopped? These are all important questions. In terms of switching to oral caffeine, well, many guidelines suggest that it is safe that when a baby is on approximately a half to 2/3 enteral feeds tolerating milk, then this would be a good time to switch to oral caffeine. That's what I do in my practice, and we know that the oral bioavailability of caffeine is excellent. This was a study that was published in 2017 looking at caffeine dosing. Panel A shows the fairly standard dosing regime with a loading dose of 20 milligrams per kilogram and a maintenance dose of 5 milligrams per kilo per day. And you can see that the target level of caffeine of 15 milligrams per liter was reached after about a week and then slowly declined down towards about 12 milligrams per liter. Moving across to panel C, this is a higher dose regime with a loading dose of 20 milligrams per kilo and a maintenance dose of 10 milligrams per kilo per day, which achieves a higher steady state as well. And what Koch and fellow authors recommended was that using a adjusted dosing regime where you start with a 20 milligrams per kilo loading dose and 5 milligrams per kilo, but then to achieve stable concentrations, increasing the caffeine citrate dose by 1 milligram per kilogram every 2 weeks, achieved the levels seen in panel B. So this is if you want to achieve a stable concentration of caffeine, but of course some would argue that that might not be necessary. So when should we stop caffeine? Well, we need to avoid unnecessary delays in discharge. There is enormous variability between babies, as you know, that when apnea resolves, so using a fixed gestational age may mean that we're continuing caffeine unnecessarily. And one author, Eichenwald, recommended for, in terms of a guideline, that if a baby has been free of clinically significant apnea or bradycardia events and is off positive pressure respiratory support for 5 to 7 days or at 33 to 34 weeks, then this should be the time to come off caffeine. There is, however, some evidence that longer courses of caffeine continue to reduce the frequency of intermittent hypoxia. And I think that we all recognize that intermittent hypoxia is associated with poorer outcomes and is something that we should work hard to avoid. Babies should certainly be free of apneas for 5 to 7 days before they're discharged home, bearing in mind, in particular, the long half-life of caffeine as well. So this is an example guideline from one NHS group in the southwest of the UK, where if a baby meets a criteria for caffeine, then it will be started. This would be for all babies under 30 weeks or below 1,500 grams who are on non-invasive respiratory support or are about to be extubated. In addition, if babies are showing apnea of prematurity, or require early extubation or weaning off IPPV between 30 and 34 weeks, they would consider using caffeine as well. And then they refer to their caffeine monograph, which gives the standard doses. Babies should be monitored for oxygen saturations and heart rate, and then they stop caffeine when babies have not required positive airway support or shown episodes of apnea for 5 days and at least 5 days prior to discharge. Monitoring is then stopped 48 hours after the caffeine is discontinued. And this seems like a perfectly reasonable example of a guideline. Their stopping criteria are mainly symptom-based rather than gestation-based, and some people could argue that given the positive effects on neurodevelopment from the CAP trial, maybe babies should stay on caffeine until 34 weeks. I have to admit that I would prefer to use a symptom-based approach. We must avoid hypoxic episodes, but I think that we should be giving caffeine to babies who don't need it. A lot of people worry about the effects of caffeine on sleep. We all know that caffeine and sleep are important. Adenosine is an endogenous sleep factor, and in our brains, it inhibits the wake-promoting neurons, the A1 receptors in the basal forebrain, and it activates the sleep-active neurons at the A2A receptors in the rostral forebrain. And therefore, that cup of coffee provides some competitive antagonism by promoting wakefulness and causing fragmentation of sleep. And therefore, we know the effects of caffeine in us. Indeed, that's part of the reason we drink coffee. And therefore, there are understandable concerns that caffeine might disrupt sleep in preterm babies. So this was an interesting study that was published last year by Gilbert Koch and his group, which really gives quite a lot of reassurance to that. They did videographic recordings in preterm babies, looking to see whether they were wakeful and whether they were in active sleep or quiet sleep. So the largest proportion of sleep in preterm babies is active sleep, and this is a predecessor for rapid eye movement, REM sleep. And as babies become more mature, the proportion of active sleep goes down towards term. Quiet sleep, on the other hand, is non-REM sleep. It's slow wave on an EEG, and it's considered to be very important for physical regeneration, cerebral regeneration, and immune development. And quiet sleep remains stable regardless of gestation. So this study, they looked at babies below 28 weeks and above 28 weeks. Below 28 weeks, they saw no differences at all in wakefulness, active sleep, or quiet sleep. And above 28 weeks, you can see the graphs here, they showed a statistically significant increase in wakefulness and a commensurate decrease in active sleep. So the presence of caffeine, as the caffeine levels increased, seemed to increase wakefulness, but not at the cost of quiet sleep. Regardless of caffeine levels, the quiet sleep remained the same. And the authors concluded that caffeine does not affect the time for quiet sleep and therefore should not affect the time for physical and cerebral regeneration, which I think is very reassuring. There are even more questions that we can ask about caffeine. Does it aggravate gastroesophageal reflux? I get asked this frequently. Is it good for renal function? Should we use it for those babies who are on prostine for their duct-dependent cardiac problems to prevent apneas? And could it complement other treatments for apnea of prematurity? The answer about the reflux is probably it does. We know that caffeine causes gastric irritation, but in those babies around 32, 33 weeks who are having hypoxic episodes, it can be extremely difficult to know whether they're having severe reflux episodes, which are probably overdiagnosed, or whether they're simply having ongoing intermittent hypoxias from apneas of prematurity. And therefore, quite a careful diagnostic process is required. Is caffeine good for your kidneys? Well, the AWAKEN study, which was published in 2018, showed that there is a reduction in acute kidney injury of between 3- and 8-fold in babies who received caffeine. So it does appear to be good for your kidneys. Could it prevent apnea for babies on prostaglandin? The answer is probably yes, but the cardiologists don't like it. So that is usually a no-no. And could caffeine be used to complement other treatments for apnea of prematurity? This hasn't really been tested, but I think that watch this space is the answer. For those of you who want to read even more about caffeine, and particularly about the effects of caffeine in the developing parts of the world, there was an excellent seminars in fetal and neonatal medicine published in 2020, which was edited by Barbara Schmidt, the primary author of the CAP study, and I would direct you towards that particular publication, which is good further reading. So, in summary, caffeine is the standard treatment for apnea of prematurity. It has an excellent safety profile, and we don't do caffeine levels because that's unnecessary. It reduces the need for mechanical ventilation. It facilitates extubation success. It reduces episodes of intermittent hypoxia. It reduces the risks of bronchopulmonary dysplasia, patent ductus arteriosus, and retinopathy of prematurity. It is associated with improved motor outcomes, and it forms a really important part of our non-invasive respiratory support ethos. It should certainly routinely be used in babies under 30 weeks and be considered in more mature infants. And dosing recommendations remain to load with 20 milligrams per kilo and maintain with 5 to 10 milligrams per kilogram per day, using more if necessary. Local protocols should define whether a gestation or a symptom-based approach is preferred for stopping, but regardless of that, babies should continue to be monitored for 48 hours after stopping, and the use of caffeine should not delay discharge from hospital. I hope that's been an interesting update for you on caffeine. Thank you very much.
Peter, thank you very much. That was very nice. Let's have a look for questions concerning caffeine. I read that question to you. Caffeine and neuroprotection in term infants. Maybe it is the future direction of neuroprotection therapy. So, Peter, can you comment on that?
It's very hard to comment on that. Thanks, Boris, and thank you for the question. I am not aware that I've seen through my reading anything that particularly shows that the caffeine has been used in the context of term brain injury. And I think if we start to think about hypoxic ischemic encephalopathy and the excitotoxic environment that exists in the brain around those sort of times, I have to admit I would be slightly anxious about giving caffeine unless I really understood what the role of competitive adenosine antagonism might be in that. So I suspect that it is one of those things where we probably need some good animal data to support, but it is not, as far as I am aware, a molecule that has been particularly studied for neuroprotection. But I'm happy to learn from my esteemed colleagues if I've missed something there.
I would like to put up a second question that goes also into the direction of brain function. Would you give caffeine for babies with seizures?
So we know that very rarely babies who have overdoses of caffeine, and I have to say that overdose of caffeine is pretty infrequent because we tend to use the standard dose most of the time. But in some of the studies where higher doses have been reported, some people have reported that babies can have arrhythmias and they can have seizures as a result of caffeine. But these seem to be incredibly rare effects. So I don't think there's any evidence that caffeine particularly causes seizures. In terms of using it for its adenosine competitiveness, I don't know. I have not seen that being used. And I think that there are probably better anticonvulsants than using caffeine, to be honest. It's one of those things that I would be not want to be the first to use in a baby for seizures. I think that's fair to say.
Thank you. Arunas, do you want to comment on that? Or Ram?
No, the question was not to use caffeine as an anticonvulsant. The question was if the baby has seizures due to IVH or something, would you continue caffeine in that patient?
Oh, I see. Okay, well, that's probably different as well. I think I would carry on caffeine for some of its other effects in a baby who was having seizures. But it's really interesting because preterm seizures are almost certainly very under-recognized. We would rely on, most people would rely on clinical observations, and I'm not sure that people are terribly good at observing seizures in babies at the best of times. And until we get to a point where we are routinely monitoring babies' brains for presence of seizures and probably using electronic algorithms to detect those seizures, because we can't be watching them 24 hours a day. I suspect we are using caffeine in the presence of seizures, whether we know it or not. So I wouldn't say that's something that I would necessarily stop.
Okay, and the last question that we have in this list: when do you wean caffeine in a baby with BPD?
So I wouldn't wean caffeine differently to a baby without BPD. There is, of course, the argument that use of caffeine may help to prevent BPD. And the definition of BPD might be the one that says that they're still requiring oxygen or respiratory support by the time they're 36 weeks corrected age. Now, my practice would be to get them off caffeine before that point. So I think I would normally try and get caffeine off at around 32, 33 weeks, and then manage BPD in other ways. Our experience has been that the severity of BPD that we're seeing is much less nowadays than it used to be, and therefore, whilst babies may be going home in oxygen or being diagnosed as BPD, a lot of them seem to have grown out of their oxygen requirement by the time they reach their correct their estimated date of delivery. And so I don't think that I alter my weaning of caffeine, particularly on whether a baby has an ongoing oxygen requirement at 32 weeks. And if there's no evidence of apneas of prematurity, then I'm quite keen to stop medication that may not be of obvious ongoing benefit.
Good. And there's a really practical follow-up question. Before extubation, do you recommend a second loading dose of caffeine?
Well, if you go back to what I talked about during the talk, there is this ongoing controversy about whether babies who are ventilated should be started on caffeine. And I thought the results to the poll, well, the two polls was really interesting, because it would appear that more people would give caffeine to a ventilated baby than would give caffeine to a non-ventilated baby. I would like to turn the results of the poll on their head. I think that as we get to a point where we think that a baby is coming off a ventilator, there is good evidence that successful extubation is facilitated by the loading of caffeine. If you have loaded a baby with caffeine and been unable to extubate them and have not carried on with the caffeine, then you might consider reloading them prior to extubation, yes. If you have loaded them with caffeine and then started maintenance caffeine and kept that going, then I think you're in a world which is fairly evidence-free. And you can probably justify a decision to give an extra load of caffeine or not give additional caffeine. And you will know with hindsight whether that was a good decision if the extubation was successful or not. I think if you're dealing with babies who are difficult to extubate, then making sure that they are loaded with caffeine is good practice.
Very nice answer. I will recommend that the two of us do a study and correlate the caffeine input of the attending neonatologist with the caffeine protocol. Other questions, comments from the panel? Professor Ramanathan.
As we know that caffeine metabolism gets accelerated as the baby's gestation age advances, there are some studies where they measured caffeine levels and then it starts to go down. Therefore, it may be reasonable to either, some studies suggest, some authors have suggested you just keep increasing the dose of caffeine every week by 1 or 2 milligrams per kilo so that the levels are not subtherapeutic. So what is your comment on that?
Yeah, so I showed that study by Koch from 2017, which showed that quite nicely using a loading dose of 20 and a maintenance dose of 5, that over time, the caffeine level does decrease. And if you use an adjusting regime, which actually increases the dose by 1 milligram per kilogram every 1 to 2 weeks, that maintains a more steady state dose, aiming for 15 milligrams per liter. But that's a very technical view of the world. And most of the time, as time goes on and apnea of prematurity becomes less prevalent and less severe, it probably isn't necessary. I think we have to remember what we're trying to do here. What we're trying to do is prevent intermittent hypoxia, because intermittent hypoxia is not good for you. And provided that babies are not having regular episodes of severe intermittent hypoxia, then I see no reason to routinely top up their medicines, especially as we're not actually measuring caffeine levels. We're going to be making some assumptions. So I think my clinical practice is to personalize the treatment to the baby, although I completely accept that as time goes on, we may be relatively giving a lower caffeine concentration. But if that is achieving the outcome that we want, and that is the prevention of apnea of prematurity and intermittent hypoxia, then I think that's absolutely fine.
So, ladies and gentlemen, we have reached 10 minutes past 3 in Central European time. I suggest that we have a 10-minute break and start sharp at 3:20 Central European time. And Peter and I will go and fill up our coffee cups, and then we will discuss about the reason why not to start caffeine in preterm babies, because I see caffeine as an integral part of trying to keep the babies from the ventilator and as short as possible on the ventilator. So in this overall strategy, I look at the data in the same way as you, but I have a little bit different conclusions, since caffeine is one of the best studied drugs that we actually use. And if we think about the evidence behind antibiotics that we use, then we are well off with caffeine information. Okay, so let's have 10 minutes break. Artem, can you please facilitate that? So, ladies and gentlemen, it is 3:20. I hope you have redosed. I helped myself to a double dose. Peter, I'm going for the 10 milligrams, not the 5. And Artem, can you please start the first case, which is entitled Use of a Clinical Score to Predict Immediate Outcome After Neonatal Transport, which is presented by Dr. Oana Boanta from Sibiu, Romania.
Hello, my name is Oana Boanta. I'm a neonatologist in the maternity hospital Sibiu, Romania, a level 3 unit. And I will talk shortly today about the use of a clinical score to predict immediate outcome after neonatal transport. How we came down to this? So in the previous years, we faced a large number of babies being transferred from lower level units. And because our clinical experience told us that these babies has a poor outcome, a poor early outcome after transport, we thought to search the literature for a score or a test that could allow us a better objective evaluation of the short-term prognosis of these babies. So searching the literature, we found Dr. Rattold's article from the International Journal of Emergency Medicine from 2014. And he was speaking about neonatal transport in resource-restricted settings, a simple clinical score at arrival, and it's predicting mortality. We have in Romania a law regarding regionalization of perinatal care, but in the previous years was too little respected. And even with rigid application of this regionalization criteria, at risk birth will still occur in lower level units, and sick newborns will still be submitted to our superior level units. So our main aim in our study was evaluation of the clinical score proposed by Dr. Rattold to our population of newborns to predict immediate outcome after neonatal transfer. This clinical score of the sick newborn is composed from 7 variables, clinical and paraclinical ones, and depending on the severity, they are marked with 0, 1, or 2 points. So our study was comprised 350 newborns that were submitted to our unit between 2015 and 2018. Clinical data were retrospectively and prospectively collected from the clinical charts. Our main outcome was the correlation of the SNS score with death risk, and our secondary outcomes were correlation of this score with a composite outcome that included intraventricular hemorrhage grade 3 or 4, PVR, severe ROP, and death. Other specific correlations were made with known risk factors for unfavorable outcome: gestational age, birth weight, male gender, NEC, BPD, sepsis, and anemia. Statistical analysis was made using SPSS for Windows. In our study, the mean gestational age was 35.5 weeks, so 53.6% from all the babies were preterm. And in the first chart, we can see that the rate of the transfer per year And in 2018, we can see a marked drop in these numbers due to our interventions. So we decided to train the doctors and the neonatology nurses from lower level units regarding resuscitation and neonatal stabilization before and during transport. So we can see our result after doing the trainings. Our results, so in our study, the mean birth weight was 2,430 grams. The mean age at admission was 7 hours, and mostly the majority of the cases came from level 1 units. The majority of the babies admitted to our level associated early sepsis, but we can see that also we had severe cases of EVH and ROP. Regarding the SNS score, in our study, the mean score was 11.1 with a median of 12 points, but we can see that we still recorded that at 30 points at admission, that at higher scores. So it's not always so relevant. We try to do some correlation between SNS score and with death and composite outcome. In both cases, a score under or equal 7 had the higher specificity and positive predictive value. Also, a score under or equal 12 had the higher sensibility. If we made some correlation or association between other risk factors and complication, we can see that comparing the babies with unfavorable outcome with those with good clinical evolution, we can see some statistical significant differences between these babies regarding hours to admission, the SNS score, APGAR score at 1 minute, hospitalization length. Also, the babies with unfavorable outcome associated more frequently severe EVH, ROP, chronic lung disease, late sepsis, and PVL. So what went well? In the original study that comprised 303 neonates with almost similar reasons for transfer as ours, the mean SNS score was 10 for all the study group and 6 for death, while the predictive limit was under or equal 8. The mean SNS score in our study was 11.1. So the SNS score can be used to predict the outcome immediately after transfer. A low SNS score being associated not only with death, but also with the composite score of unfavorable outcome indicated by serious conditions complicating the clinical course. Use of the score enable physicians not only to inform parents, but also to then identify infants requiring special attention and interventions to prevent unfavorable outcome. What could we have done better? So we can make statistical analysis on gestational age, because preterm infants have different risk factors for unfavorable outcome compared with term ones. The predictive score may be improved by adding other parameters, and an increased number of cases may add more value to the score. What would we do differently next time? We are proposing to repeat this analysis, but separately on preterm and term infants, and continue to enroll more infants in this study. And the clinical observation was made as regards the negative impact of hypothermia at admission. So we are considering to add body temperature to the study and modify it. So an analysis of this different score may help us to find the best variant for our population of infants. And now at the end, it was a short presentation, some discussion points for the audience. Do regionalization of perinatal care work in your country? Are you using any standardized score to predict outcome immediately after transfer? And if you believe that usage of such a score may change the staff perspective in this case. Thank you.
Thank you very much. That is a very interesting study. May I ask you, before we go to your questions that you put forward, have you shared this data with the colleagues in the peripheral hospitals who then attended those deliveries, took care of the babies, and then transferred the babies to you?
Hello to everyone. No, I don't think this data was given to our colleagues, but we continue to train them. So we, in 2008 and 2019, we trained the colleagues from lower level units, but also the colleagues from the emergency unit that help us with the transfer, so to transport our neonates. So we can see now results. We have a small number of cases being transferred to our unit, because the risk births are happening in our unit now, so they don't need transfer from lower levels.
Excellent, because that is the double bind situation. If you organize your transport well, then the people in the peripheral hospitals take it, may have the tendency to take it lighter that a preterm birth happens in their ward, and don't do everything to move the baby in utero to the major center. So shall we go back to the questions you have raised? Does the score affect the attitude of the medical personnel towards the baby? Who wants to address that from the panelists?
I will have a go. Thanks, Oana. That was a really interesting bit of work, and builds on some of the publications that you've referenced from the group in South India. I think that I don't have experience of using things like the SNS scores for transport. But what I do have experience of using scoring systems for things like HIE. And my experience of those is that sometimes you risk losing a bit of detail and losing a feel for what the primary problem is. So I guess one of my questions for you is that when you have been talking to your colleagues either about the retrospective babies that you've evaluated or the prospective use, have you still been able to have a very clear view as to why a transfer is being requested, what the primary problem is? Or do you find that the score somehow muddies the water a bit?
I'm sure that the score it's not relevant only. It combines the severity of the illness, but also the quality of the transport. So it's not only about transport; it's also about the severity of the illness. Our problem in our study is hypothermia. This is a problem of transport.
And may I read a question from Daniela? This score was based on clinical items. Did you assess the score before the transfer and after the transfer in order to pinpoint the impact of the transport on the clinical condition?
For example, the temperature, as you told.
Yeah, it's a good idea, but it's a good one. Yeah, we can suggest to our colleagues that request the transfer to do this score at
pickup.
At pickup, yeah, and then at arrival we can also do the score and see the quality of the transport and the impact of the transport on the baby.
How closely are the vitals monitored of the baby during the transport? I have come to appreciate that Romania is a huge country and that you spend quite some time on those transports.
Yeah, some in our region, maybe 2 hours. So from my knowledge, they are good. They are monitorized correctly. So I know temperature, maybe not all the time. It depends from what level the baby comes. When he comes from a level 1 unit, sometimes he comes with not with the best qualified team, you know, from the emergency. It's the basic ambulance.
Okay.
So there can be a problem, because when they come with the high experienced team, with the emergency unit transport team, they came maybe in a good condition. They monitor us temperature, heart rate, SpO2, blood pressure, glucose levels. So they are doing well.
Okay. So for the sake of time, we have to move to the next presentation. Thank you very much. I hope your questions were addressed. And Artem, please start with the next case, which is entitled Clinical Management in Newborns with Chylothorax and Chyloperiitoneum. The presenter is Dr. Pavelko from the Ukraine.
Hello, dear colleagues. My name is Ksenia Pavelka. I'm an anesthesiologist. I work in neonatal intensive care unit in Zaporozhye Regional Children's Hospital, Ukraine. Today, I'm going to speak about one interesting case. So let me just turn on my presentation. Wait a minute, please. As I have already told, I'm going to speak about one interesting case, and that case report is devoted to a significant problem in modern neonatology, the difficulties of management of preterm newborns with chylothorax and chyloperiitoneum. What was the basic problems and diagnosis of a child? He has congenital spontaneous chylothorax and chyloperiitoneum, the early onset of neonatal sepsis pneumonia, and additional problems were intraventricular hemorrhage and hypoxic ischemic encephalopathy. History of the child and initial medical care. Mother is 19 years old. It was first pregnancy with bilateral twins. During this pregnancy, an inflammatory process progressed, causing premature rupture of membranes. The first child was delivered by essential way. Second child developed umbilical cord prolapse. Manual fetal extraction was unsuccessful. That's why cesarean section was performed. The newborn was followed by mechanical ventilation, and after stabilization in 18 hours, newborn was followed, was transported to Regional Child Hospital. When the patient enrolled to our department, first of all, we suspected the early onset of neonatal sepsis. That's why we took blood culture to confirm the diagnosis. But on the 5th day of life, patient developed total edema. For the start, we excluded acute kidney injury. And then on the X-ray of the lung, we found out fluid in the pleural cavity, and fluid in the abdominal cavity was found by ultrasound. To confirm the diagnosis, we installed tubes in abdominal and chest cavity and both cavities, and we received fluid from both cavities, and that it was lymph. Now, more about our treatment. We've started antibiotic therapy, ampicillin and amikacin, nothing per os, and used combined total parenteral feeding by SPGAN recommendation. We replaced the PICC line catheter because it could be causing the problem, and we have given the baby a creotide 24 days and gave albumin twice. We also extended mechanical ventilation, but nothing has changed during 20 days. We decided to expand the therapy and added norepinephrine infusion, and fluorodesis was performed twice by 10% iodine, povidone iodine. Now about our positive aspects of our case. So we are able to avoid major surgery and late onset sepsis. Chest tubes was removed on the 29th day of life. The child was discharged from a hospital on the 6th day of life with a grow-up outcome comparable to fetal curves, even after prolonged TPN. What we could done better? Could we increase the creatide dose up to 7 milligrams per kilo? Could we have done fluorodesis earlier, for example, on the 5th day of an infective treatment? Or could we give more parenteral or enteral proteins to the child up to 3.5 grams per kilo to improve grow-up rates? What we will do definitely next time, probably we'll be using norepinephrine earlier. With the development of edema, we will think about lymphedema earlier, and we will try to find an opportunity to prepare solutions for TPN in a pharmacy in more aseptic ways. In my conclusion, I would like to emphasize that prolonged parenteral nutrition can ensure the growth of newborns comparable to intrauterine if the target doses are achieved. And second, impaired lymphatic drainage is a dangerous disease that requires the work of multidisciplinary team. And we would like to know about your experience in treatment patients with cholothorax and coloperitoneum. When and how do you do surgical or do you do chemical fluorodesis? What recommendations do you follow up for treatment newborns with cholothorax and coloperitoneum? And we would like to know your opinion about current issue, because we have not known about causes of cholothorax in case before. Thank you for your attention. Hello.
Hi.
Hi.
Thank you very much for your presentation. You have put forward very clear-cut questions, and one of your questions was the dose with octreotide. So I was asking the panel who would like to answer that. Ram, can we hear your opinion on that?
Yes. I mean, there are studies and the dosing recommendations, Australia, New Zealand registry is very good resource. And there are cases where they've used up to 12 micrograms per kilo, and the baby doesn't respond within 2 to 3 days, then you gradually wean the baby up. There is no use in continuing. So there is a maximum dose people have recommended.
Thank you.
And you were sitting far below that. So that answers your first question. The second, could we have done fluorodesis earlier, for example, after 5 days of ineffective treatment? One way of looking at that is that you calculate the volume of the fluid that is being produced per kilogram. I don't remember whether you presented this as milliliters per kilogram per day. So if I have missed that, please tell me.
Fluorodesis chemical.
No. The fluid that the cholothorax is producing. So when do you have to surgically intervene? That was your question. And my answer would be if more than 100 milliliters per kilogram per day are being produced and lost.
How did we calculate it? Yes?
Yes.
We received, sorry, I don't remember, but we received about 100 milliliters per kilo a day in this situation.
Okay. And have you used medium chain fatty acids as well to reduce the production of,
no.
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 Okay. So let's have a look at the other questions you put forward. Yeah, parenteral and enteral proteins to the child. Have you calculated how much protein the baby lost with the drainages per day?
No, we didn't. No.
We only checked.
Okay. So now my question is to the other panelists. Other comments or remarks?
My question is why norepinephrine if you have the fluid in the third space? And so probably the solution was to increase the intravascular fluid more than use a inotropic drug in general. And so the first line therapy, I think, was to increase, to improve the protein, the level of protein, and after to work eventually if you fails with inotropics.
The use of norepinephrine was the suggestion of from our cardiothoracic surgeons, and they told us that not so high doses of epinephrine can constrict lymphatic vessels, maybe. But in our clinic, we don't have special equipment and we don't have cardiothoracic surgeons that will manage with these problems by in surgical way.
Okay, thank you. For the sake of time, we move on to the last and final presentation. Thank you very much. And I hope our discussion helped you with your questions. The last presentation will be entitled Important Right Pulmonary Hyperinflation Associated with Bronchopulmonary Dysplasia and Left Atelectatic Lung. It will be given by Dr. Diana Arnautu from Constanța in Romania. Artem, please start.
I am Diana Arnautu from Constanța, Romania. I'm a neonatologist from Neonatology Department of Constanța County Emergency Hospital, and I present you the case Important Right Pulmonary Hyperinflation Associated with Bronchopulmonary Dysplasia and Left Atelectatic Lung. We present a case report of a preterm infant, female, 29 weeks of gestation, second twin, a monokaryotic monoamniotic twin pregnancy, initially with mild RDS that was treated with surfactant, nasal CPAP, continuous mandatory ventilation, PEIONA, with good response. At 52 days of life, the baby developed a severe pneumonia with multi-resistant Klebsiella pneumonia with an aggravating evolution. The baby is now 1 year old and she was discharged at home at 98 days of life, 2,700 grams and no respiratory distress. The newborn was stabilized in the delivery room with Neopuf and received Kurosov. After, she was admitted in NICU for RDS, treated with nasal CPAP for 5 days. In the 6th day, due to a pulmonary hemorrhage, she was intubated and put on continuous mandatory ventilation for 5 days. She also received PEIONA, antibiotherapy, nebulized beclomethasone with good pulmonary outcome. At 44 days of life and 1,700 grams, she was transferred to premise with full enteral feed by bottle with Neocate, good weight gain in a crib. But at 52 days of life, she was readmitted to NICU with severe cardiorespiratory distress and got reintubated on pressure support ventilation. Started IV ertapenem with ciprofloxacin for 6 days, then levofloxacin, trimethoprim sulfamethoxazole, fluconazole, according to the blood culture that was positive for Klebsiella pneumonia. Apparently, slight improvement, but no, the girl got worse. Here we have the lab results and the ABGs. In highlights are the day that she was readmitted in an ICU. You can see it here. And the worst days of her life in an ICU, here and here, with high leukocytosis, severe hypercapnia, 158.8 was the PCO2, the maximum, with severe compensated respiratory acidosis and increased liver enzymes. The chest X-ray evolution. The first one is at birth. The second one is at the readmission in an ICU. And the third and the fourth are with right pulmonary hyperinflation associated with bronchopulmonary dysplasia, left atelectatic lung, and the last one is at discharge. The CT scan result. The first one, next to the lab results, are in the worst day of her life, with hypoplasia of the left hemithorax, multiple cystic areas all over the right lung, alveolar consolidation in the left lobe, left lateral mediastinal deviation, and this is a suggestive aspect for cystic adenomatoid malformation. That was the radiologist thinking. The second one is at discharge. At 66 days of life, and the second blood culture with Staphylococcus epidermidis, the aggravated, unstable infant's clinical status with severe respiratory distress, important general edema, liver failure, the results of CT scan and chest X-ray and lab determined change in the treatment. We gave the baby furosemide IV, albumin, vancomycin, ciprofloxacin, oral vitamin C, nebulized beclomethasone and nebulized ipratropium bromide, and put the baby on mandatory ventilation pressure assist control with big values. At this point, we asked for suggestion and advices in another centers, third grade NICU, and the answers were the girl is without chances. But we keep on believing in her. And we saw improvement after 24 hours and the second dose of albumin. The edema remitted gradually, respiratory and liver function improved, so we could decrease the ventilation parameters according to the ABGs and changed from mandatory ventilation, pressure assist control to pressure support ventilation. Yes, we have done a lot of chest X-ray and ABGs so we could accommodate the changes step by step with the infant's need. At 30 days since she got into NICU, she was extubated with good outcome and discharged at home at 98 days of life. What went well? Of course, the first in line is that the baby was with good outcome and she got home without no respiratory distress. The fact that we could accommodate the ventilation parameters with the infant's need by taking ABGs as needed, even if sometimes we felt that it's too much or too many, gave us a live infant. We had a good feeding tolerance. We had a good cooperation with the radiologist, whom we thank. But the most important, I think, is that we had a good and complete team, infant, doctors, nurses, and parents, who believed and did everything in their power to make it happen. Here is Stefania, that's the name of the girl, at 8 days of life. And here is Stefania at 1 year. What could we have done better? Restricting contact between preemies and other infants by improving the condition in NICU. We did that. We have now a new NICU in Constanța. The results of blood culture should be possible to obtain earlier, 48 hours. This will help modulate better the antibacterial treatment. At time present, we still have the results after minimum 7 days. Monitoring the serum level of albumin in infants with edema more frequently and from the beginning. Discussion points for the audience. Was this a case of cystic adenomatoid malformation according to the CT results, or was the right lobe bronchopulmonary dysplasia? Was the Klebsiella the treatment, or both the cause of the liver failure? What is your experience with levofloxacin and ciprofloxacin in NICU's infants? I thank you for your attention, and also Stefania.
Thank you very much. That was a very impressive case. So let's get started with your questions. So your first question is, what is the, your last question was, what is the experience with ciprofloxacin and what was the other one?
Levofloxacin.
Yeah, for which both there are no neonatal admissions and permissions to use. we have no protocol for that in our hospital, and so if it is used, it is then based on the prescription of the individual attending neonatologist. I don't know how this is in the other hospitals, and I put this question to the panelists.
We do not use this drug. As you know, tendon damage has been reported in pediatric patients, as well as, if I remember right, prolonged QT interval and cardiac arrhythmias. So I have no experience using it in newborns.
And with levofloxacin, it is also described that the bilirubin excretion is impaired. So that is, of course, something you do not want to hamper with in this patient population. So the next question you asked is, was the Klebsiella the treatment or both the cause of liver failure? If this was multiple choice, I would say all of the above.
Okay.
But that is very, very difficult to tell. Rem, what is your thought about that?
Yeah, I agree. There are multiple factors here. So I don't think we can specifically say one led to the liver failure compared to the other factor.
Okay.
And your most important question, was this a case of cystic adenomatoid malformation according to the CT result, or was it a right lobe bronchopulmonary dysplasia? I tried to magnify these CT scans because you presented all of them, but pretty small. I don't make a call on that. I would then go with the expertise of the radiologist.
Oh, okay. But if that was the right diagnosis, then didn't the girl need a surgical intervention?
No, I mean, you have, if you don't agree with the reading of your radiologist, then you should get a second radiologist to read those scans. But they were not of a quality that I could read them since they were so small. Sorry.
Can I share my screen so to put on the screen just the CT?
Let's try that. Artem,
Okay.
be prepared if everything breaks down.
Hope not.
I mean, it is a space-occupying lesion anyway. So, in my opinion, that huge lesion has to be taken out.
So let's hope I did what it should have done.
I don't think it's BPD or bronchopulmonary sequestration.
No.
No. I am sharing my screen. Do you see my screen?
We see your folder with the different X-rays and the two
yes, and I'm
CT
trying
scans.
to open. Yes, I'm trying to open the first CT, and it's open.
So my other question is, if the baby is doing so fine, and have you considered to do a follow-up CT scan?
After discharging, the last one is after the treatment and in the discharge date. I mean, like 30 days after the first.
Exactly. And that is now 11 months ago.
Yes. No, another CT. No, we didn't.
So if
Boris, sorry, but the course was very fast of this patient, and so the improvement, in my opinion, is like a pneumatocoele. I think it's a pneumatocoele, as we saw. I saw one or two cases of like this with Staphylococcus, pneumonia by Staphylococcus. And so with a few days of steroids, the patient significantly improves, at least on the chest raise. And so I think that probably the most probably diagnosis is a pneumatocoele like this, or infection of a lobus. I don't know, but is an infection, and otherwise, if there's a malformation, it has not a sudden improvement and such a good outcome, pulmonary lung, and also radiological outcome.
Honestly, I didn't follow the radiologist diagnosis, so I I know my knowledge and my instinct, and I treated the signs, not the diagnosis.
Oops.
So
That's always a good question, a good idea.
Good point, yeah.
Absolutely. So, but if you are concerned, you are following this baby?
yes, I am.
So that is
The neurodevelopmental is not outcome is not so good as I would like to be. Slightly hypothonia, but as language and speech, they are okay at this age. She already says like mama and 2 syllables. She is repeated after us in her language, but repeated the sentences, the words. But for motoric development is not so good.
well, that is a pity. However, that baby was seriously sick, and you fought on and were successful. So time is up. Thank you very much for the participants.
Thank you very much.
And we see you, hopefully all of you, tomorrow afternoon again. Thank you for all presenters.
Thank you.
Thank you.
Thank you, everyone.
Very nice being together with you.
Thank you all.